Where are we in 2024? This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by EDLI and managed by Perfect Square. I'm grateful to Mr. Ashutosh Shukla, Mr. Agarwal, and the team from EDLI, Mr. Yash Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Vaishali Sanchorawala from Boston, all our discussants who are eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening. Tomorrow morning, Sunday, 13th October, 11:30 Indian Standard Time, we have Dr. Delphine Rie from Paris speaking to us about CML, the possible changes in the treatment of first-line setting in 2024-25, French time, 8 a.m. Discussants today, and there are a large number who are seriously interested in being on this side of the screen to discuss directly with Dr. Vaishali Sanchorawala. In interest of time, I will just tell you the names. Dr. Aditi Kaskar, Dr. Aditya Jandial, Dr. Akanksha Garg, Dr. Amit Kaur Kaler, Dr. Anbarasan Sekar, Dr. Ankit Batra, Dr. Ankit Rayani, Surgeon Commander Dr. Arun V.A., Dr. Asha Shah, Dr. Ashraf Haq Chaudhary from Bangladesh, Dr. Avriti Baveja, Dr. Bhauseb Bagal, Dr. Cecil Ross, Dr. Chandrakala, Dr. Chirag Shah, Dr. Deep Gala, Dr. Dibya Jyoti Prusti, Dr. Fahima Hassan, Dr. Hamza Dalal, Group Captain Dr. Harshit Khurana, Dr. Hin Mia Thanda from Myanmar, Dr. Khushbu Jain, Dr. Kripa Bajaj, Dr. Kunal Chattani, Dr. Kunal Goyal, Colonel Dr. Kundan Mishra, Dr. Malikarjun Kalashetty, Dr. Mona Vijayan, Dr. Nilesh Vasekar, Dr. Nitin Gupta, Colonel Dr. P. Suresh, Dr. Pawan Kumar Singh, Dr. Prabodh Kumar Das, Dr. Pradeep K. Reddy, Dr. Prashant Mehta, Dr. Priyanka Srivastava, Dr. Rajan Yadav, Dr. Rajat Bajaj, Dr. Rajesh Patil, Dr. Riya Balika, Dr. Sanket Shah, Dr. Surat Bala, Dr. Satarupa Mahopatra, Dr. Saurabh Bhave, Dr. Shriram Kane, Dr. Siddhesh Kalantri, Dr. Subhaprakash Sanyal, Dr. Sudarshan Pandit, Dr. Tejaswini Gudi Bande, Dr. Upendra Sharma, Dr. Vikas Talreja, Dr. Vishwadeep Khushbu, Dr. Y. Mon Thant from Myanmar, and now the introduction of our guest speaker, Dr. Vaishali Sanchorawala. I don't need to introduce her. She has done a great service to all of us by repeatedly conducting webinars on the subject of AL amyloidosis and other aspects of amyloidosis and making us wiser in treating our patients so effectively. To complete the formalities, however, she is Director of Stem Cell Transplantation Program at Boston Medical Center. She is Director of Amyloidosis Center, Boston University School of Medicine. Skinner Professor of Amyloidosis Research in the Department of Medicine. Associate Editor of Amyloid, which is a journal of protein folding disorders. Secretary of the International Society of Amyloidosis 2022. Her research has led and defined the field of AL amyloidosis. She is recognized as one of the leading international experts and a key opinion leader in amyloidosis. With numerous publications and meeting presentations, she is one of the pioneers in the field of clinical research in AL amyloidosis. Her work in the treatment of AL amyloidosis has resulted in the evolution of the standard of care for these patients. She's currently heading several clinical trials in the treatment of AL amyloidosis, two of which were conducted nationally through SWOG 0115 and SWOG 1702 and led to the publications in peer-reviewed journals. She's part of the faculty at major international conferences in amyloidosis and has given many invited talks nationally as well as internationally. As an expert on amyloidosis, she is active in various non-profit organizations, regulatory authorities, and funding bodies. She is a member of the Executive Steering Committee of Amyloidosis Research Consortium, which is developing pathways to education, patient voice, development of treatment, and access to novel therapies. She has helped to create and cultivate the next generation of physician scientists around clinical research in this field. She regularly attends several patient information seminars and support group meetings in the US. Outside of roles of direct research and clinical care, she has an interest in working with charity organizations as well. The product of St. GS Medical College, KEM Hospital, Mumbai, India. She did a residency, University of Medicine and Dentistry of New Jersey, US. She did fellowship in hematology oncology from Boston Medical Center, US. Fellowship in stem cell transplant, again from Boston Medical Center. And today, she's speaking to us on ASCT in AL amyloidosis, where are we in 2024. Thank you. I'll stop sharing and hand over the platform to her.
So greetings, everyone. I'm Vaishali Sanchrawala, and thank you to Professor Agarwal for inviting me here today and for that introduction, which was extremely kind, which was obviously not really, capturing who I am. I'm a product of GS Medical College, and I was there in 1980s. I did do a talk on diagnosis and risk stratification for AL amyloidosis. I think it was 6 months ago. And at that time, there were many questions about role of stem cell transplantation amidst this emerging therapies, specifically with the Andromeda clinical trial in the treatment of AL amyloidosis. So I kind of self-invited myself that let's do a talk on role of stem cell transplantation in 2024 in the treatment of AL amyloidosis. Sorry. So these are my disclosures. So just 1 second. So this is a 40-year longitudinal natural history study from Boston University Amyloidosis Center for 2,400 patients with AL amyloidosis. And as you can see, the 5-year overall survival has improved dramatically from the mid-1980s to mid-2010. It has improved from 15% 5-year overall survival to 48% in the most contemporary era. I know this is not moving forward, but anyway. Maybe I should do it this way. So this is the therapeutic landscape. And this, the improvement in overall survival is really related to expanding therapeutic landscape. The expanding therapeutic landscape in AL amyloidosis is mainly adopted from the treatment of multiple myeloma. Most of these treatments that are directed towards plasma cell dyscrasia or the precursor protein production, which is the plasma cell dyscrasia. And as you can see, the response rates have increased dramatically in the past several decades. Let me see if I can just move. Okay, here. So high-dose melphalan, an autologous stem cell transplantation, was first performed and developed for the treatment of AL amyloidosis in the mid-1990s at Boston University Amyloidosis Center. The development of this treatment approach was prompted by promising results of similar regimens in multiple myeloma, cousin of AL amyloidosis. Objectives of the initial clinical trials for stem cell transplantation were to determine tolerability of this treatment approach in patients with multi-system, multi-organ involvement from amyloidosis. Second, to determine efficacy of this treatment in inducing complete hematologic response, and we hypothesized and argued that complete hematologic response might be better than that in multiple myeloma because the plasma cell burden in AL amyloidosis is lower than multiple myeloma. And finally, to determine whether complete hematologic response leads to reversal of amyloid-related diseases and improved survival. Prior to 1990s, two historical pivotal randomized clinical trial of oral melphalan and prednisone, one performed at Boston University by Professor Martha Skinner and other one performed at the Mayo Clinic by Professor Robert Kyle, suggested that the median overall survival improved from 6 to 8 months to 12 to 18 months with treatment of oral melphalan and prednisone. However, long-term overall survival, hematologic complete responses, and organ reversal or organ dysfunction reversal were very rare with this type of treatment. Patients who were not treated or were treated with placebo or colchicine, the median overall survival was 6 to 8 months from diagnosis. This was our first report of first 5 patients treated with dose-intensive melphalan with autologous peripheral blood stem cell transplantation for AL amyloidosis. I was a fellow at that time in training, and we found that patients did achieve hematologic complete response and also organ dysfunction improved. We then looked at the first 80 patients who underwent high-dose melphalan stem cell transplant and their long-term outcome. The median overall survival of these first 80 patients was greater than 10 years for those who achieved a complete hematologic response compared to 4.1 years for those who did not achieve a complete hematologic response. Since then, my clinical research strategies have included clinical trials to improve the proportion of patients who ultimately achieve a complete hematologic response, as this would lead to better overall survival. These trials all have been published, and they were all prospective investigator-initiated clinical trials. We will go through this journey in the next few slides. This was one of the first clinical trials of high-dose melphalan and autologous stem cell transplantation as initial therapy or following 2 cycles of oral melphalan and prednisone, the standard of care treatment at that time, followed by stem cell transplantation in a prospective randomized trial where we enrolled 100 patients with new diagnosis of AL amyloidosis, and they were randomized to receive 2 cycles of oral melphalan prednisone followed by stem cell transplant or stem cell transplant directly without induction therapy. And we found that newly diagnosed patients with AL amyloidosis did not benefit from treatment with oral melphalan prednisone prior to stem cell transplant with respect to either survival or hematologic response. And moreover, patients with AL amyloidosis and cardiac involvement demonstrated survival disadvantage if stem cell transplant was delayed by initial treatment with oral therapy. This trial now is being criticized, and even then was criticized because the induction therapy is not contemporary with oral melphalan prednisone, again, standard of care treatment at the time of trial design. This trial then was followed by tandem cycles of high-dose melphalan stem cell transplant, and we enrolled 65 patients with AL amyloidosis on this prospective phase 2 trial. And the conclusions were that tandem cycles are feasible for selected patients with AL amyloidosis and can increase the proportion of patients who ultimately achieve a complete hematologic response with an overall complete hematologic response of 67%. This then was followed by a pilot study of 10 patients where bortezomib was incorporated into the conditioning regimen of high-dose melphalan. Bortezomib was administered at 1.0 milligrams per meter square on day -6, day -3, and then 2 days following stem cell transplant. high-dose melphalan was given at 140 or 200 milligrams per meter square in 2 divided doses, and we did not find any unexpected non-hematologic toxicities or treatment-related mortality. And hematologic complete response and very good partial response occurred in 88% of the patients. This was then followed by a prospective phase 2 trial of 35 patients with AL amyloidosis, where 2 cycles of induction therapy with bortezomib was given, followed by stem cell transplantation. In this phase 2 trial, 35 patients were enrolled, and we noted a very high rate of hematologic response with 63% complete hematologic response and 37% very good partial hematologic response. There were no negative impact of bortezomib induction on stem cell collection. However, 14% of the patients, so that is 5 out of 35 patients who were eligible for stem cell transplant at the time of enrollment, did not proceed to stem cell transplant due to clinical deterioration during induction therapy. And it was just 2 cycles of induction therapy. Despite that, 5 patients were unable to proceed because either they developed syncopal episodes, they developed congestive heart failure requiring hospitalizations, or developed end-stage renal disease. Long-term follow-up analysis of this phase 2 trial was recently published with a median follow-up time of 77 months, and the median overall survival and progression-free survival were not reached. Renal and cardiac responses occurred in 65% and 88% respectively at 5 years post-stem cell transplantation, and hematologic relapses were rare in 15% at median of 42 months. A Chinese prospective randomized control trial of induction therapy with bortezomib and dexamethasone followed by stem cell transplant versus stem cell transplant alone in the treatment of renal AL amyloidosis also noted that hematologic complete response at 1 year and overall survival at 2 years were in favor of bortezomib induction therapy followed by stem cell transplant. HOVON 104 trial was a European trial which also conducted a phase 2 trial of 50 patients with new diagnosis of AL amyloidosis who received 4 cycles of bortezomib-based induction therapy followed by stem cell transplantation. And even in this trial, 15 patients out of 50, so that's 30%, did not proceed to stem cell transplant due to complications during induction therapy. And the intention to treat analysis, hematologic complete response rate was 32% because of early dropout from the trial. And this conclusion of this trial was that this was not an effective therapy based on induction therapy failure or based on dropout at the induction therapy time. So we conclude that induction therapy should be used with caution prior to stem cell transplant in patients with AL amyloidosis, as complications during induction therapy can make patients ineligible for stem cell transplantation. Since the advent of novel agents have been incorporated into different phases of stem cell transplantation. Adjuvant therapy of thalidomide dexamethasone after stem cell transplant was studied in a phase 2 trial showing an improvement in hematologic response rate at 42%. Consolidation therapy with bortezomib dexamethasone following stem cell transplant also was studied in a phase 2 trial showing 86% improvement in hematologic complete responses. Maintenance therapy has not been studied in clinical trials and is not currently recommended following stem cell transplantation, unlike maintenance therapy in multiple myeloma following stem cell transplant. I'm sorry. So eligibility criteria broadly are listed over here. Tissue diagnosis of amyloidosis as demonstrated by green birefringin when stained with Congo red staining. evidence of a plasma cell dyscrasia, and at least one vital organ involvement. Soft tissues, macroglossia are not considered vital organ involvement. Eligibility criteria also have required minimum measures of performance status, cardiac function, pulmonary function, and hemodynamic stability. Patients have been treated on several sequential IRB-approved clinical trials, and age, renal function, time from diagnosis, prior treatment, and conditioning regimen have varied among clinical trials. We reported on 648 patients who have undergone treatment with stem cell transplantation from 1994 to 2021. So in 20 years, we have treated 648 patients with AL amyloidosis with stem cell transplantation. The organ involvements for this particular group of patients is quite typical for AL amyloidosis. Majority of the patients received 200 milligrams per meter square of melphalan or full high-dose melphalan, and 40% received 140 milligram per meter square or modified high-dose melphalan. Bortezomib-based induction therapy was used in 10% of patients. Hematologic responses were evaluable in 584 of 648 patients. There were, several patients who were not evaluable because of early death, either related to treatment or lost to follow-up, although that number is pretty low. Hematologic complete response, defined as absence of monoclonal protein in serum and urine by immunofixation electrophoresis, normal serum free light chain concentration and ratio, and less than 5% plasma cells, which are polytypic on bone marrow examination, was achieved by 39% of evaluable patients post-stem cell transplantation. On an intention to treat analysis, 35% achieved a hematologic complete response, and CR and VGPR was achieved by 68% of the patients. Median duration of complete hematologic response was 12.3 years, and the 5% risk of relapse after being in hematologic complete response for 15 years. The duration of complete response was shorter if plasma cell percent was greater than 10%. Median event-free survival was 3.3 years, and event-free survival was defined as a next line of therapy or death, whichever occurred first. Median follow-up for all patients was 8 years, and median overall survival following stem cell transplant was 7.6 years, and 10-year projected overall survival in the most contemporary era is 67%. Treatment response does impact overall survival as well as event-free survival. Median event-free survival was 11 years for those who achieved a complete hematologic response following stem cell transplant, and median overall survival is 15 years with those who achieved a complete response. 20-year overall survival for the entire cohort is 30%. We also looked at short and long-term safety of stem cell transplantation. Treatment-related mortality, defined as deaths occurring within 100 days of stem cell transplant, occurred in 7.6% of patients. But as shown on the right curve, the day plus 100 mortality is reduced to 3.3% in the most contemporary era. We also looked at therapy-related myelodysplastic syndrome and AML risk following stem cell transplant. Competing risk analysis accounting for death was performed, and the cumulative incidence was 3.3 years at 25 years. Organ responses were also evident following stem cell transplantation, and as shown in this slide, renal response, cardiac response, and liver responses were noted following stem cell transplant. Deeper the hematologic response, better the renal response. So again, the goal of treatment should be to achieve a complete hematologic response or very good partial response. This is a large registry data from CIBMTR, and our dear friend Anita D'Souza published this of approximately 1,500 patients who were registered in the CIBMTR registry who have undergone stem cell transplant for AL amyloidosis. And as you can see in this Kaplan-Meier survival curve, that the 5-year overall survival has improved from 55% in the mid-1990s to 77% in mid-2010. Mayo Clinic also reported on their long-term outcome of 159 patients treated with stem cell transplant, again, estimated 15-year overall survival of 33%. UK National Amyloidosis Center, Dr. Wecklicker's group, also reported on 264 patients undergoing stem cell transplantation with a median overall survival of 8.2 years and a 20-year long-term survival of 33%. Now, the role of stem cell transplant in 2024. The disclosure here is that there is no direct comparison, no randomized clinical trials of non-stem cell transplant regimens versus stem cell transplant with respect to hematologic response, overall survival and progression-free survival, organ response, and quality of life measures in patients with AL amyloidosis. However, we do have some data which is not a direct comparison, so I do suggest to take this data with some caution. This is from our center, from the longitudinal natural history study of 40 years, showing that overall survival of patients who were treated with stem cell transplantation in the most contemporary era of 2010 to 2019 is 76%, and it is 42% for those who were treated with non-stem cell transplant regimens. Again, to the caution that this is not a randomized clinical trial. It is a, okay, this is not going forward again. This is a retrospective longitudinal natural history study from our database. This is from Mayo Clinic, again showing similar results. Patients who were treated with stem cell transplantation from 2010 to 2014, the 2-year overall survival was 94%. And for those who were treated with non-stem cell transplant regimen, the 2-year overall survival was 47%. Quality of life also improves following stem cell transplantation. We actually published this earlier 20 years ago of SF36. It's a patient-reported outcome measure instrument which measures health-related quality of life. And it is called short form 36. And what we saw is that mental component summary and physical component summary of SF36 reached improved following stem cell transplantation and reached the population norm by 1 to 2 years following stem cell transplantation. So again, the burden of disease as demonstrated by SF36, which is demonstrated in the red graph on the left side, which shows that the quality of life is pretty poor in patients who are diagnosed with AL amyloidosis. I'm sorry about this. Now, we also looked at longitudinal analysis of quality of life based on SF36 in AL amyloidosis. Again, not a randomized trial, but from our database, that the clinically meaningful improvement in physical component summary and mental component summary occurred in 41% and 47% of patients following stem cell transplantation, and it occurred in 23 and 29% respectively following non-stem cell transplant regimens. Now, role of transplant center. So Absolutely. There is, because this is a rare disease with multi-organ involvement, there is definitely benefit of high volume centers based on this paper from Dr. D'Souza in the CIBMTR study. High volume centers were defined as those conducting more than 4 stem cell transplantation for AL amyloidosis per year. And as you can see here, 30-day and 100-day mortality were much lower for high volume centers. We developed with European Hematology Association and International Society of Amyloidosis Working Group, which was an international collaborative effort with representation from 6 different countries, and developed these guidelines for stem cell transplantation in AL amyloidosis. This was published in Amyloid Journal in 2022, and these guidelines go over eligibility criteria, role of induction therapy, stem cell mobilization and collection, and risk-adapted melphalan dosing, and the most importantly, the supportive care following stem cell transplantation in AL amyloidosis. There are certain nuances of stem cell transplantation in AL amyloidosis. This is a paper from our group looking at renal injury after stem cell transplantation in patients with AL amyloidosis. Acute kidney injury occurred in almost 30% of patients undergoing stem cell transplant and was associated with increased overall mortality and increased risk of developing end-stage kidney disease leading to dialysis. The etiology of AKI following stem cell transplant in AL amyloidosis were various etiologies, including acute tubular necrosis, pre-renal conditions, cardiorenal physiology, so it is not always related to AL amyloidosis. We also have published on atrial fibrillation following stem cell transplantation in patients with AL amyloidosis. The risk of development of atrial fibrillation is approximately 13%, and patients who have prior history of atrial fibrillation, who are on anticoagulation and treatments to control their heart rates, have an increased risk of developing atrial fibrillation during stem cell transplantation. Last few slides on the Andromeda clinical trial data, which is going to be updated at the ASH meeting with a median follow-up of 48 months. Now, this was published in 2021 with a median follow-up time of 14 months, showing, and as all of you know, Andromeda clinical trial is a global international phase 3 trial in patients with newly diagnosed AL amyloidosis, randomizing them to VCD or bortezomib, cyclophosphamide, dexamethasone alone, or VCD plus daratumumab. And hematologic response rates were significantly higher for those treated with VCD plus daratumumab, as well as major organ deterioration progression-free survival was also higher or favorable for dara-VCD. Major organ deterioration progression-free survival was defined as a composite endpoint of death, hematologic progression, or development of organ failure requiring heart transplantation or renal dialysis or renal transplantation. Now, the median time to hematologic response is quite rapid when patients are randomized to receive VCD plus DARA 60 days versus 85 days. And the role of stem cell transplantation in the setting of Andromeda data, because as you can see that the hematologic complete response with dara-VCD is almost 60%, 56.9%. And this the data holds up even in this ASH presentation, which is coming up in December. So Southwest Oncology Group, Patrick Hagan is one of our junior faculty members, has developed this phase 3 randomized clinical trial where patients with newly diagnosed AL amyloidosis are treated with 3 cycles of induction therapy with dara-VCD, the Andromeda regimen, followed by randomization to continuation of dara-VCD consolidation and dara maintenance, exactly like Andromeda, versus stem cell transplantation. And then even the stem cell transplantation arm would get maintenance for 2 years. The primary objectives of this clinical trial are to compare major organ deterioration progression-free survival between stem cell transplant and non-stem cell transplant arms. And the secondary objectives are quality of life measures, overall survival, time to next treatment, hematologic responses, and organ responses. The accrual goal for this trial is 380 patients, and this trial has already started enrolling. We've enrolled about, I think, 3 or 4 patients have already been enrolled in this trial. And with that, I would like to thank all the members of the multidisciplinary clinical team, as well as multidisciplinary basic science team who work on the scenes and behind the scenes to make this disease more manageable. And thank you for your attention, and thank you and sorry for the technical difficulties.
Thank you so much, Dr. Vaishali Sanchorawala, for updating us on such a massive experience of autologous stem cell transplant, probably biggest in the world. You began it and you have followed it up for so many decades, and you updated us with all the information. So you can raise hands for putting up questions. Meanwhile, can I ask you the first question? So what are your eligibility criteria for autologous transplant at the moment? In other words, who are not eligible for transplant straight away?
Right. So, that's a great question. And again, I think that, I used to always debate about pros of stem cell transplant. And next weekend, I have to debate about cons of stem cell transplant. And I'm having palpitations because, this is not what I have done for my entire life. Having said that, we used to transplant about 30 patients with AL amyloidosis every year. In 2023 and 2022, we did about single digits, 5 to 10 patients. So again, even in the United States and at Boston University, it is hard to convince us, physicians, as well as patients to really undergo stem cell transplant, because Dara-CyBorD, Dara-VCD is a very easy regimen to tolerate, and it is easily available. And, we achieve very, very good hematologic responses and also organ responses. What we don't have is the long-term data of Dara-VCD. We don't know, are they all going to relapse after 2 years? Are they all going to, not achieve long-term survival? So we don't know all that. Having said that, yes, patients who have advanced cardiac involvement, we are not transplanting. We don't have really true cutoffs for cardiac biomarkers, but in the working group guidelines from International Society of Amyloidosis, we did say that BNP of greater than, or NT-proBNP of greater than 5,000, we should not really offer transplant. Creatinine clearance or estimated GFR of less than 30, we should not really transplant. Patients on dialysis, I do get little concerned about transplanting them. Patients with pleural effusions, patients with systolic blood pressures of less than 90, I do not offer them transplants because their morbidity associated with transplant is pretty significant. So these are kind of broad exclusion criteria.
So if your patient is unfit for transplant today, and after a couple of cycles of your induction therapy, he now becomes fit for transplant from these criteria, will you transplant him?
Right, great question. Again, I refer you to the guidelines. And in that, we did say that if you achieve a hematologic complete response after induction therapy, you should not proceed with stem cell transplant unless it is a myeloma level burden. Then, yes, absolutely. But if it is less than 5% plasma cells, less than 10% plasma cells, we generally don't do stem cell transplant because I feel that the organs need a kind of time to recover. Because, if you remember from my spring talk, that the best organ responses can take 24 to 36 months to occur following treatment. So, I think that, rather than attacking them with second line of treatment or consolidating them with stem cell transplant, if they are in complete hematologic response, I would not recommend transplant unless they are part of the SWOG trial, because there people are just getting randomized. So again, outside of a clinical trial, I would not do it.
Okay, one last question from me. So outside clinical trial, what is your consolidation and maintenance therapy today?
So we don't really, post stem cell transplant, we don't do any consolidation or maintenance. We do it only if they have not achieved a CR or VGPR. And I don't really start anything for the first 6 months because I think that they just need to kind of calm down and the organs need a chance to recover because, the organs are really, really badly beaten up with this disease. So I think it's and we do it all the time for myeloma. So I think that, this is a little bit different.
And non-transplant patients, you give them maintenance?
Yeah, so that's a good, so that we follow what we've done with Andromeda because we don't have any data that, do we really need that 2 years of daratumumab? Probably not, but we are doing it and it is so well tolerated. They are coming once a month. We have subcutaneous daratumumab. So it is extremely easy to do it and patients are feeling better. They don't want to really come off it. So we do continue it because that is what the data is.
Dr. Siddesh, your question.
Hey everyone. So, first question I had was what minimum dose of melphalan you think is effective while doing transplant? So, what is the lowest dose you think is effective? And second question is, what are your secrets that you keep mortality so low while doing the transplants?
And you need Dr. Sanchurawala. I've been in the business for over 30 years. No. So the dose of melphalan, I think that's an important question because SWOG 0115 trial that, I led, where we enrolled, 120 patients on that trial was a trial of 100 milligram per meter square because we were very concerned. This was in late 1990s. We were very concerned that Southwest Oncology Group centers are going to be all across the country and it is going to be low volume center, high volume center, that they are going to have very high treatment related morbidity and mortality. So we developed that trial as 100 milligrams per meter square and then 3 months later or 6 months later, second cycle of 100 milligrams per meter square. So it was, but the responses were very, very low. The hematologic complete responses were, I think, like 20%, less than 30%. So I don't think I would recommend that in this day and age. I think that we have done 140, or we do recommend in the guidelines to do 140 milligrams per meter square for those who have EGFRs of between 20 and 50 or 30 and 50 or something like that. So 140 for renal impairment patients, but otherwise 200 because the hematologic responses and long-term data are much better with 200 milligrams per meter square of melphalan compared to 140. And treatment-related mortality, I think it is experience. I think, again, experience obviously does play a role in every disease, right? But I think it is also, patient selection is critical because in 1990, when I started this 1994, we did not have any treatment available. It was oral melphalan or do stem cell transplant. We had no bortezomib. In 2007, when we did the trial of bortezomib, I said bortezomib is a game changer. Now I say daratumumab is a game changer. So we have so many other options that I think that, patient selection becomes critical. We also do a lot of functional assessment. So it's not just based on biomarkers. We do stair climb. We do 6-minute walk test. If patients can climb 3 flights of stairs, I think their functional status is going to be reasonably good with advanced cardiac involvement. But if they can climb not 1 flight of stairs. So this week I saw a patient who walked 120 meters in 6 minutes, which is not going to really, that gentleman obviously was not offered stem cell transplant. And even in this whole data set of 650 patients, only 20% of newly diagnosed patients are eligible to receive stem cell transplant. So, 80% are not. And, it is definitely challenging.
Sure.
Thank you so much, ma'am.
Thank you, Siddesh. Dr. Deep Gala.
Thank you, ma'am, for this wonderful overview. Ma'am, I have one question regarding patients with gastrointestinal amyloidosis. So, ma'am, do you consider them for transplant? And if yes, then what will be the dose of melphalan again? And what will be your criteria for selecting such a patient for transplant and otherwise not selecting them for transplant?
So, again, you have to be very careful with GI amyloidosis because in GI amyloidosis, there is an entity called localized GI amyloidosis. So that in that particular, so when I did my talk in spring, I said that there is systemic amyloidosis and localized amyloidosis. In localized amyloidosis, the amyloid fibril deposition is occurring at the site of precursor protein production, meaning that it is localized to the GI tract. There is no evidence of systemic plasma cell dyscrasia. Serum and urine immunofixation electrophoresis does not show monoclonal protein. Free light chains are normal, and bone marrow is negative for plasma cell dyscrasia. These patients are considered localized GI AL amyloidosis, and there is no indication for treatment directed towards plasma cell dyscrasia. So those patients should not be treated with chemotherapy, with stem cell transplant, with, daratumumab. Those patients need supportive care only. If they are having diarrhea, they are having reflux, or they're having constipation, or they're having bleeding. So, you are basically doing supportive care. If they are having small intestinal bacterial overgrowth, things like that, you are just doing supportive care. And sometimes it is very debilitating to have GI amyloidosis. But if you have GI amyloidosis as part of systemic disease with liver, kidney, heart, or any other involvement, then I think it becomes a little bit of a challenge. Most of our stem cell transplant protocols and standard operating procedures, we do say that GI amyloidosis with evidence of bleeding, requiring blood transfusions, requiring, or associated with acquired factor 10 deficiency, we would not transplant those patients because you are going to have GI bleeding and GI hemorrhage during period of thrombocytopenia. I also have a little paragraph that I always put in my note that keep their hemoglobins greater than 10, keep their platelets greater than 50, keep, during post-stem cell transplant, if it is part of systemic AL amyloidosis.
Yes, ma'am. Thank you, ma'am. Ma'am, I have one more scenario. Actually, we have a patient of AL amyloidosis who is 24 months into the disease, and he's been in complete remission at around from 8 to 10 months of the treatment. He's been in complete remission. But since 13 months of disease, he has started developing recurrent pleural effusion. He had cardiac amyloidosis to start with, and with 13, 14 months of treatment, he has now started developing recurrent pleural effusions requiring multiple drainage procedures for the same. But otherwise, his hematologic response is in complete CR. So, ma'am, how should we manage such a patient? He also has concurrent hypertension along with his systolic blood pressure remains around 85 and 90. So, what should be the line of treatment? And is there any role of
He's
SGLT2
in deep
inhibitors?
trouble, or you are in deep trouble. See, the unfortunate part is that the interplay of this organ response versus organ progression versus organ recovery is very complex, and we don't understand it. So we are trying to stop the amyloidogenic precursor protein production by chemotherapy, by DARAS-VCD with stem cell transplant. But what happens in the organs is not really very well understood. If you were to rebiopsy his heart, if you were to rebiopsy his whatever organ that had it, it's going to be positive. It's going to be loaded with amyloid. But their surrogate markers of organ dysfunction do get better, which are the biomarkers. And it happens only even in Andromeda, it happens only in 58% of the patients, 59 to 50, 60% of the patients. Stem cell transplant, 70% of the patients. 30%, 40% do not have organ responses. And therefore, those antifibril or amyloid busting agents are being developed to really see this. I do remain worried about your patient because heart can, if the recurrent pleural effusions, low blood pressure is probably all related to bad heart. We have used Pleurex tubes for drainage of pleural effusions, that they go home with that so they can at least have a little bit quality of life. For low blood pressures related to autonomic neuropathy, not obviously related to bad heart and the cardiac output, we have used midodrine. I've also started using a lot of droxidopa droxidopa, it is very expensive here in the United States. It's impossible to really get prior authorization for the insurance companies, but I don't know if it is available in India or not. Probably, I think it might be. But, again, droxidopa, 100, 200 milligrams 3 times a day, along with midodrine. We do a lot of compression stockings, abdominal binders to increase venous return. They should not really eat a lot of hot food because, after hot food, the blood pressures usually goes down. So, small frequent meals, which are room temperature, things like that, again, these are all little tricks, but it's going to be a challenge. There is nothing that we have yet to remove amyloid fibril deposition from any organ.
And ma'am, any value of adding SGLT2 inhibitors for such patients?
That's a $1 million question. I know. So, again, SGLT2, right, I'm going to take it too, but, I think that it is, as I make fun of everybody that, I want to take SGLT2 and I want to take venetoclax because then I'll live till 100 years old because, I said venetoclax is, it's like, it takes care of all diseases. But SGLT2 is not really totally studied properly. We are using it all the time, specifically in TTR cardiac amyloidosis, but we are also using it in AL amyloidosis. And I think that, if patients, what I have been told is if patients have renal insufficiency, then it might be a little challenging. But otherwise, Jardiance or, empagliflozin or Farxiga in 10 milligrams a day, you could try it. I think there are no side effects. One of my patients with bad heart who was placed on SGLT2, every time we placed him on it, his kidney function went up. He developed acute kidney injury with creatinine of, from 1.1, 1.2 to 2.2, 2.5, because it does cause glucosuria and it does cause, diuresis. So, you may have to adjust the dose of diuretics and things like that.
Thank you, ma'am.
Thank you, Dr. D. We'll take one question from the audience. Dr. Shyam has a question. How important is cyclophosphamide in Cybor D with DARA? The Cybor role of cyclophosphamide.
Again, I'm a big fan of alkylating agents. So I think that, yes, if I were to really, so, DARA VCD I start. So, patients, like Dr. Gala's patient, very bad heart involvement, advanced cardiac involvement, you don't really know how they are going to do with, dexamethasone and whatnot, I would start with single agent DARA. And then, after 2 or 3 cycles, if they have not had an adequate hematologic response, then I would add Cybor-D. Now, Velcade or bortezomib is a little bit of a problem because it can cause low blood pressure, unmasking of autonomic neuropathy, and it also may have some heart-related issues. So I never ever start more than 1 milligram per meter square. I do cyclophosphamide just because, my threshold for decreasing or stopping Velcade is pretty significant. And the cyclophosphamide, I do it as oral. I don't do intravenous. I do it, I know it's 50 milligram tablets only. So, when we do 300 milligrams per meter square, it's a lot of tablets. But I do cyclophosphamide orally. And I feel that, that cyclophosphamide is it's an alkylating agent. And, we've always used alkylating agents in plasma cell neoplasm. So I would probably feel that it is important. Again, I will tell you, there is a paper from Greek group, Dr. Kastridis' group, and they had looked at, again, retrospective study, not really a prospective trial. They had looked at Cybor-D versus Velcade Dex. So the Cy was taken off, and they found that the responses and everything else was the same. So maybe Cy has no role, but, I don't really know. I think my threshold for dropping Velcade is higher in advanced cardiac amyloidosis.
May I ask you, oral cyclophosphamide advantage over injectable?
Yeah, I don't know, I think injectable is just because I feel that it is, again, it goes with IV fluids. And if patients have heart problems or heart involvement and renal involvement, you are giving them 250, 500 cc's of normal saline, So that would be the only disadvantage. But, I think that daratumumab, and initially when we started, we were doing IV and it was a big bag. Now it is available subcutaneously, so it is very easy.
Dr. Avriti?
Thank you very much, sir. Thank you very much, ma'am, for this wonderful talk. Ma'am, I just wanted to know how to manage a case of diffuse tracheal amyloidosis. I lately came across a 76 years old male who had stridor and he had a diffuse tracheal amyloidosis. Bone marrow was normal, and we could not demonstrate we could not demonstrate the protein there. But we were having an M spike of approximately 0.5 gram per year. So we anticipated that it is an AL amyloidosis, and we started on Botidexa for that patient. He has responded well to that therapy, but we don't know how to go about it, when to change the therapy, and convincing the patient for DARA without clear cut diagnostic criteria. It becomes very challenging at times.
Right. So your patient has localized AL amyloidosis of the tracheobronchial tree.
Yes.
So this is not systemic AL amyloidosis. So I would not go after the plasma cell dyscrasia. I know that he has an M spike of 0.5 grams per deciliter, which is probably all coming from the trachea. So it is very, very common to have localized AL amyloidosis of airways, tracheobronchial tree, urinary bladder, GI tract. We've reported it in breast. We've reported it in prostate. We've reported it in lungs. So it is extremely common. Tracheobronchial amyloid, specifically because of stridor and things like that, what we have also reported is low dose radiation. So first is all, ENT needs to be involved. They need to scrape it off, laser it, whatnot. Obviously scraping has to be done by a very, very experienced ENT, because you don't want to cause scarring and you don't want to cause additional problem with fibrosis. So, scraping it with laser or scraping it with surgically, and then, doing very low dose radiation, just, about, 600 gray or things like, so just to kind of kill the plasma cells in the trachea so that there is no progression.
Ma'am, in this case, we had... sorry, ma'am, sorry to...
No, that's
actually,
okay. No.
In this case, we had discussed it with our ENT team. They were saying that the patient can't be taken for laser ablation, and we also discussed with our radiotherapy team, and they were not willing to go for radiotherapy.
So I
in
will
this
send
case.
you a paper. I will send you
Okay,
our
ma'am.
paper, that we published, and I know that this is not the standard, but this is what is going to be effective.
Okay,
there is nothing else that is going to be effective for
Thank
this.
you, ma'am.
And
Thank you.
giving chemotherapy is obviously not the right treatment, because the pathophysiology is not making sense.
Yes, ma'am.
Yeah.
What happens, Dr. Avriti, is that our ENT and radiotherapists have zero experience with these problems. So they're sort of scared of touching these patients. So
Yes, sir.
You have to force them and you have to show them the literature. Okay, Dr. Arun.
Thank you very much, sir.
Thank you, Dr. Agarwal, first for putting us through a great interactive session with one of the leading experts in the field. Lovely to hear you through, ma'am, throughout the talk and the liveliness you have. If you permit, sir, I have 4 questions. I've noted it down for ma'am. Ma'am, the first question is, in fact, what subset of patients actually could go to transplant directly? Are you taking up some of the patients directly to transplant? Is it to do with the bone marrow plasma clone burden, or is it to do with the organ function? Some of the patients are eligible for an upfront transplant. So what is your thought process regarding that, ma'am?
Right. So generally speaking, at our institution, if patients have less than 20% plasma cells, we take them directly to transplant, because we were really burnt, with those 2 clinical trials where we did induction therapy and patients kind of fell off because they developed, progression, progression of their organ dysfunction. So less than 20% plasma cells, renal stage 1, cardiac stage 1, I think we are directly taking them through transplant. Obviously, the insurance approval and all that can take 2 to 3 weeks. So, and the patients, they are coming from all over the country, so they have to make hotel reservations and things like that. So that, again, that may be a little bit of a challenge, but otherwise, we definitely, do them directly. If patients have higher burden of plasma cell dyscrasia, then I think induction therapy with few cycles of Dara-Cybo-D, and then if they're not in CR, the issue is that when you do induction therapy with Dara-VCD, most of them do go into CR. So then, you don't want to transplant them. And, patients feel so much better and patients are doing so much better that they don't really want to get transplanted, So that is what our approach is.
Thank you, ma'am. Ma'am, taking on from the transplant part, and somebody who transplant, and when you assess the patient 3 monthly with the hematological responses, so where do you actually start intervening? Somebody who doesn't goes into a VGPR at 3 months, 6 months, when do you start thinking that my transplant has not probably worked and you need to put in another line of management? So what is your timelines? I would want to know, like 3 months, 6 months, a year, or what do you actually react to a response which is less than a VGPR?
Right. So we assess hematologic response at 6 months because, as I said earlier, I want people to really, really kind of recover from the toxicities of transplant and their organs to get better. So, we assess hematologic response at 6 months post-transplant if they are not in CR or VGPR, and if they've not had an organ response, second line of treatment is offered. We have 3 clinical trials for upfront or newly diagnosed patients with AL amyloidosis, and we have about 4 or 5 trials for relapsed AL amyloidosis. So I do try to enroll them on clinical trials, but if they are not eligible or if they are not interested, then they go on standard of treatment. And then, again, it would be probably data-based if they've not seen data upfront, or bortezomib-based, or if they are a translocation 11-14, then maybe venetoclax.
The next question was on the MRD in amyloidosis, ma'am. At least in myeloma, we have been chasing that the MRD concept, and I could see the Andromeda data. We had deep remissions, MRD negativity. Do you think it's a prime time for clinical practice for MRD in myeloma? One, and in amyloid. And second thing is, could MRD sustain undetectable? Could tease out those cases who may not require a 2-year DARA maintenance post transplant? What do you think is how MRD is shaping up in AL amyloid?
So MRD definitely is not ready for prime time in AL amyloidosis. I think that other issue with MRD is also that, it is a bone marrow based test. So have we really started making treatment decisions based on MRD results? No. We have shown that, yes, patients who achieved MRD negativity do have better organ responses than patients who are in CR and MRD positive. So yes, the small clone does kind of make a little bit of a difference. But, we've also seen that patients who are MRD positive have had very prolonged organ responses and remissions. So we are not ready. We are, I think, looking at all this data. We don't know how to interpret it. We don't know what to do with resurgence of MRD because we are doing them longitudinally now and whatnot, I think that the other thing is that, yes, the next generation flow, it is a bone marrow fresh specimen. It has to go to an outside institution and all that. So it is a little bit of a challenge, but it can be done. I think that sometimes I feel that if patients are really having massive proteinuria, they are in hematologic CR, and if they are MRD positive and I want now the creatinine is 1.5 from 0.8 initially, I may suggest to do single agent DARA or something like that. But I'm generally not making decisions based on MRD unless the organs are really, really progressing rapidly.
One last question, ma'am. This was regarding the IgM amyloid. Do you think is that a subset which actually should be transplanted upfront? Because I think there is some data that the chemo regimens don't do that better. You think the transplant works better in that subset, ma'am? The IgM amyloid. Ma'am?
So that's what we showed, in one of the papers, and which was, so IgM amyloidosis is different. There are two types of IgM amyloidosis. Majority of them are Waldenstrom's associated AL amyloidosis or LPL associated AL amyloidosis. And in those patients, I treat them as Waldenstrom's treatment, not with venetoclax up front or not with ibrutinib, because I think BTK inhibitors are not very well tolerated in AL amyloidosis. But we have used a lot of rituximab bendamustine. And, they don't even need to have complete responses. Even with just partial response, their organs get better right away. So rituximab bendamustine, BDR regimen, which is bortezomib, dexamethasone, rituximab, can be used for Waldenstrom or LPL associated IgM amyloidosis. Now, there is also, 50-60% would have plasma cell dyscrasia associated IgM AL amyloidosis. And in those patients, I would treat them as Darasibordine, or I would treat them as, I would not offer treatment because it is just IgM rising from plasma cells. I would not do rituximab bendamustine in those patients. But, patients who have LPL or Waldenstrom's associated, I think, the Waldenstrom's treatment does work.
Thank you. Thank you.
And transplant, you asked about transplant.
Yeah.
So, we are not really doing it or whatever, but, yes, our data does show that transplant has a very, very, very long remissions post transplant, and the organs respond beautifully as well. So, Steve Trion and he used to send all his patients with Waldenstrom associated AL to me, and I would transplant them, and they are all in remissions for a long period of time. So yes, transplant does work. We are not doing it as much anymore, but yes.
Thank you, Arun. So Dr. Khushbu.
Good evening, sir. Majority of things you have covered already. I have the basic doubts we have in India is first is diagnostic dilemma. Most of the time we have something called some like Congo red positivity, and we have some amyloid deposition somewhere, but we want it to be proven mass spec, which we don't have. So first request would be, can we open a channel as a nation to some center in US or some other place, which we can send the samples, which is practical. Like your cost of testing is very different in US as compared to in India. One thing is we are not able to test for the exact, we're not able to subtype the amyloid here. So that is one major issue. Then second, I have to ask you regarding, few of our patients might, like they come with some decent control of amyloid and have kidney failure, and they come for consult regarding kidney transplant. So is there any threshold which you 12 months or maybe response maintaining for few months, so then we can clear for transplant? And third opinion I would require would be when there is inhibition of factor 10, like there is a bleeding, acute bleeding and active disease is there. How do you manage that? I find it very difficult to stop being per se at the get-go, because disease control will take some time and amyloid may take more longer time. So how do you get about it when it is bleeding?
Excellent questions. I think as you very well pointed out, I think the biggest challenge in India is accurate diagnosis. I think that is the biggest challenge, because there are just so many doctors and so many centers and so many patients, and there is no standardization. The Congo red stain can be falsely positive because it's a very fastidious stain, and it comes back positive, and then we don't really know what is going on. So that is the first thing. The second thing is the mass spectrometry or accurate identification of the amyloid precursor protein. Again, I know because there is also a lot of infections, tuberculosis, and other GI infections in India, that AA amyloidosis, which arises from serum amyloid A protein affecting the kidneys, is also quite common. So, and the treatment is completely different because the treatment is controlling the underlying disease that is causing this inflammatory response to start forming amyloid fibrils from serum amyloid A protein. So I think it is extremely challenging. Mayo Clinic laboratories, so mass spectrometry is done it says Mayo Clinic, but it's not really Mayo Clinic because they're not part of Mayo Clinic. But in everything in Rochester, Minnesota is called Mayo Clinic. So it is Mayo Clinic Laboratories, which is a different organization altogether. And we don't have mass spectrometry at our institution either. But all the hospitals in the United States have a contract with Mayo Clinic Lab. And the contract is that, yes, we will send the specimens, and then the institution that sends the specimen bills the insurance company. Okay, so that the contract is set, and so our contract is for $900 per specimen of mass spectrometry, and $900 that, again, we charge it to the insurance company. Most of the times the insurance company pays, but we can send specimens to Mayo Clinic, and it takes them 2 weeks to generate a report. But that is what happens. And, I'm sure they have international affiliations as well, that, yes, you could use it, again, there's nothing central in India, meaning that there's not one center or one person that this is where all the Congo Reds are done and this is where it is sent. So I think that is absolutely critical. I think Dr. Khurana and I had a case together in Surat that, this lady had all clinical features of amyloidosis, had a Congo Red, which was positive. And, again, the concern was that this is AL amyloidosis. And, he did everything. Free light chain assays, serum immunofixation, electrophoresis. I said, no, do urine immunofixation also. Did urine immunofixation, electrophoresis, and everything came back negative. All her plasma cell dyscrasia markers were negative. And then, I said, maybe that the Congo Red, which was done on an abdominal fat, which was falsely positive. And I think that, again, abdominal fat Congo Reds can be falsely positive. I think kidney biopsy Congo Red, I would say that most of the times it's not going to be falsely positive. Or heart biopsy Congo Red is not going to be falsely positive. But fat, because, the Congo Red is picked up by the collagen, by the elastin. Congo Red in the bone marrow can be falsely positive as well. So I think diagnosis is absolutely critical. I think differentiation between systemic amyloidosis and localized amyloidosis is also, I think, critical. Because yes, localized GI, localized tracheobronchial, they do not need systemic therapy. So that's the first part. The second part is acquired factor 10 deficiency. We have a poster at ASH. Out of 1,200 patients, 88 patients with factor 10 deficiency. So it is not a very common presentation of acquired factor 10 deficiency, but it is on everybody's boards and exams, because acquired factor 10 deficiency, unless proven otherwise, it is AL amyloidosis. And there is no true really treatment. Obviously, we can use FFP if patients are bleeding. Which again, it's a lot of volume, how much FFP can you pour in and whatnot. But we have used Novo 7, activated factor 7. We have also, if they are bleeding, because, so one lady, so I used it prophylactically before stem cell transplant for a line placement. And she developed a stroke because she had a bad heart, and right. So it does cause hypercoagulation. So you have to weigh the risks and benefits. So Novo 7 I've used prothrombin, activated prothrombin complex. So PCCs we've used. There is a company that also has made a synthetic / recombinant factor 10. They are trying to develop a clinical trial, which is going to be impossible because it is 88 patients and not majority of them bleed. Only 15% of those 88 patients out of 1,500 patients had GI bleeding. Majority of them do not even have GI bleeding. So again, I think it is a little bit of a challenge. What I say, if I am taking somebody through transplant, what I say is keep their hemoglobin greater than 10, keep their platelets greater than 50. obviously, judicious use of Novo-7 and PCC if they are bleeding, things like that. And as you said, yes, hematologic complete response will improve factor 10 deficiency, but it may take a year or two before it comes back to normal. So you have to support them during that time. And the third question was, now I forget, what was it?
Kidney transplant.
Oh, yes, a very, very valid question, very important question. Solid organ transplant, absolutely. So kidney transplant, being on dialysis, and particularly in India where you have to pay for everything, it's very, very difficult. Here, dialysis is covered by Medicare. But, patients who are in complete hematologic response or very good partial response and have had maintained that response at least 12 months off therapy, they should definitely be offered kidney transplant. And with the caveat that the patients and the kidney transplanters know that if the disease recurs, it can affect the transplanted kidney and they may lose their kidney, that the donor, the patient, and the transplant physicians should know that this is not going to be all set for the rest of their lives. So that, active surveillance is very important. But hematologic CR-VGPR, a large paper from Dr. Havasi and multi-center IKMG group where we put all the patients together and we said that the renal survival, graft survival, and overall survival much better for those who received kidney transplant in hematologic CR-VGPR than who received in hematologic PR or progression.
Thank you, ma'am. One of my patient has, not my patient, nephro patient has renal amyloidosis, and on IHC they have given us AA amyloidosis. So myeloma workup, except for bone marrow, everything PET is normal. There is no paraprotein. FLCs. So I am unsure whether I can just say that okay, it is AA and I'll leave it there. So is mass spec very necessary here to, or I can just, even if I do a marrow and it is normal, or if it is abnormal, I'll get any answer. If it is normal, then what do I say to the patient?
So the IHC is AA.
Yes, ma'am. And he has no other active infection as of now, but like 10, 20 years back, he had pulmonary tuberculosis. Currently, he doesn't have anything except for protein.
Right, and the renal biopsy immunofluorescence is AA.
It is not showing kappa lambda restriction. They have
really?
in that IHC, yes, in that IHC they have done AA. Yes.
So see, I will tell you that the commercially available antibodies for immunohistochemistry are kappa, lambda, AA, and TTR. There are only 4 antibodies available. So if the patient has A fibrinogen alpha or A ApoA2 or different rarer types of amyloidosis, they are not going to be caught by immunohistochemistry or immunofluorescence. Then they will need mass spectrometry. Now, in the setting of this, you are trying to put it all together. We do some markers of inflammation. So I would do SED rate. I would do a CRP. I would do ferritin to see if any of those are elevated. Serum amyloid A levels, I think in India, some lab is doing it because, I've seen several patients, where they have serum amyloid A levels. Obviously, if that is significantly elevated, that, that is what is happening. You are inferring, you're not having a complete, but, as far as there is no evidence of plasma cell dyscrasia and renal biopsy does not have kappa or lambda, I think you generally ruled out AL amyloidosis. I feel that, that the renal amyloid also, that immunofluorescence is pretty reasonable. So they should be able to tell you, and there is an antibody available for AA and TTR. Now, TTR does not really go into the kidneys, so, that's, not really a problem, but there are other types of A fibrinogen, A ApoA2, A ApoA4, A lysozyme, they all go to the kidneys. So these are all rarer types of amyloidosis. Obviously, there's no treatment, and we we follow them and we do genetic counseling because it can be inherited into families.
If A is positive, we can reasonably be sure that it's AL.
That is correct, exactly, because AA antibody is available, and it is pretty. I think renal biopsies are reasonably okay to really not subject to mass spectrometry based on just immunofluorescence.
Okay. I had an idea like it is still not confirmatory, so we have to cross check with MS. But I got my point clear. Thank you, ma'am.
And I put the reference for the renal transplant in here, in the chat.
Thank you for that.
Thank you, ma'am.
There's some more questions for you. How do you treat severe macroglossia?
Yeah, problem. Huge problem. I know. And see, the problem with macroglossia is that it does not get better. Means that you can transplant them, put them in hematologic CR, you do daracibody, put them in hematologic CR, and if macroglossia, it will not improve. Sometimes patients say that, yes, I feel that the tongue is moving better. Yes, my speech is better, but there's no way to measure it. So you don't really know whether it is getting better or not unless the patient tells you. It is a huge problem because it causes a lot of morbidity. And we recommend all best supportive care, meaning dentist visits periodically, dental hygiene, pureed food, aspiration risks are very high, obstructive sleep apnea is very high, so CPAP at night, things like that. So again, it is all care for supportive measures. I've had patients who needed tracheostomies because the tongue was so big that they just couldn't breathe. I've had patients who required G tubes to feed them because it was just so difficult. So it is, role for glossectomy, partial glossectomy. We really haven't done that. We used to do it just because we had no treatment. But it is very difficult to do partial glossectomy because there's a lot of risk of bleeding because tongue is a very vascular structure and it has a lot of risk of bleeding and infection, and healing, it becomes a big, huge problem. So it is a little bit of a challenge.
Thank you.
But radiation would not help it because it is all amyloid fibrils.
Right. Next question is about localized amyloidosis. Do you have to demonstrate that there are local plasma cells with clonality?
No. We assume that. That is what we assume. We have to demonstrate that there is no evidence of systemic plasma cell dyscrasia. Because, GI involvement could be part and parcel of systemic disease. But we do have to make sure that there is no other organ involvement like nephrotic syndrome or congestive heart failure or heart or kidney or liver. Then we can assume that this is localized. Usually, it is picked up on screening colonoscopies. Usually it is picked up on because somebody's having diarrhea, GI bleeding, they are doing colonoscopy, they see some areas they don't like, they biopsy, and then it comes back positive. For us, here it is a lot of also issues with screening mammographies that, they see microcalcification and they biopsy it, and then it is loads of amyloid. So, in those cases, we have to make sure there is no systemic disease.
Sure. The other question is about patients with autonomic neuropathy. What is the modification of CyBO-D? Do you use carfilzomib? And if there's a cardiac involvement as well, then what do you do?
Yeah, CyBO-D is rough and tough on autonomic neuropathy. So again, severe autonomic neuropathy leading to syncopal episodes every time patient is trying to sit up, walk, whatever. It is very challenging because, as I said earlier, Velcade, bortezomib will cause hypotension. So I would start out with proper, solid supportive care first, and then use bortezomib only 1 milligram per meter square. And, the supportive care for autonomic neuropathy is behavioral modifications. Count till 10 before you change positions so that the body equilibrates. Then the second is never get dehydrated. Always keep some, salt, whatever, chips or wafers. I always tell them that have it in a bag. So if you feel dizzy, just pop some wafers, which is loaded with salt. Then, compression stockings to increase thigh high compression stocking to increase venous return. Abdominal binders. Don't eat, massive meal and then try to sit up because you will pass out. The pharmacologic measures would be midodrine or pyridostigmine or droxidopa. I've had good luck with droxidopa recently. And autonomic neuropathy does get better. So I think that your goal is to support them for 6 to 12 months, because at the end of hematologic complete response, yes, the autonomic neuropathy will improve. So unlike peripheral neuropathy, which rarely improves, or macroglossia that rarely improves, but autonomic neuropathy will get better. So I do suggest that, we have to do everything because we don't want them to pass out and hit their head and bleed into the brain.
Right. Second part of the question was whether you will replace Velcade with carfilzomib.
Oh my, I know. So carfilzomib, I know that our sponsors are makers of carfilzomib, so I should not say a whole lot, but no, so carfilzomib, has not truly been studied in AL amyloidosis except for a paper from Ashutosh Veklikar, UK National Amyloidosis Center, in patients who had significant peripheral neuropathy associated with AL amyloidosis, and he treated, I think, 5 or 10 patients with carfilzomib with some good responses. I think we had a phase 1 trial of carfilzomib, and it was a multi-center trial in the US, and the cardiac events or cardiorenal events occurred in 35% of patients. There was 1 death, 1 VTAC, and again, maybe it was not related to carfilzomib, maybe it was related to their underlying disease. But yes, so we have not been using carfilzomib in patients with ALM. I would definitely not use it up front, by no means. If really end of the line, if there's a problem, yes, maybe.
Right. And place of pomalidomide?
Yeah, obviously, these are all great questions. I tell everybody, I said, India has so much brain power, it is unreal. That all, even if you don't see so many patients, but your questions are so valid and so engaging, that I love to do this because I feel that, oh my goodness, you guys all, you may have seen 1 or 2 patients with amyloidosis in your entire career, but you have the right questions, this factor 10 deficiency and how to manage. Oh my God, this is, anyway. So, now, what was the question? Obviously, I forget the question. Pomalidomide. So immunomodulatory agents, I would say lenalidomide is not well tolerated. We did a clinical trial of 82 patients with AL amyloidosis who were treated with lenalidomide. And what we found in the first 10 patients that nobody could handle 25 milligrams of lenalidomide a day. So we ended up dose reducing to 15 and 10. Because everybody had performance status of 4, they were fatigued, they were unable to really manage lives and whatnot. So the MTD, maximally tolerated dose of lenalidomide for patients with relapsed AL amyloidosis is 15 milligrams. And there was a side-by-side trial going on at Mayo Clinic by Dr. Dispensary, and she had the same findings. So yes, lenalidomide no more than 15 a day. Pomalidomide, on the other hand, also was studied in a phase 2 trial, and maximally tolerated dose is 4 milligrams. And it is better tolerated than lenalidomide. And we do use it post-Dara-Cybor-D. Patients are older, don't want transplant, and are not 11-14. So I would do pomalidomide, 4 milligrams a day, 3 weeks on, 1 week off, just like our myeloma dosing. But I don't really combine it. I don't really do it as triplets and quadruplets. I do it as just palm dex. Again, we have a clinical trial of Dara palm dex for relapsed AL. Nothing earth-shattering in that trial. So I think palm dex by itself, I think would be reasonable option. I think the thing to remember with palm or lenalidomide are that there is paradoxical increase in cardiac biomarkers. It's something happens in the test tube that I don't really understand it. But 80% of patients who are on PALM, so it is very difficult. They all have increase in their cardiac biomarkers, and it becomes extremely hard to assess cardiac response while they are on therapy.
The other question is about venetoclax. What is your accompanying drugs for a relapsed 11-14 positive AL amyloidosis?
A great question. Venetoclax is such a powerful drug that I would just do single agent with a little bit of dex. There are trials ongoing with venetoclax, ixazomib dex, all oral regimen, and venetoclax dara dex, but I don't think you really need a partner. I think venetoclax does put everybody that I've treated with 11-14 into solid remissions, and they're all MRD negative remissions. I think what we don't know is the duration of therapy. Do you continue after 6 cycles? Do you continue after 12 cycles? Do you do is till relapse, till progression? All that we don't know. And I haven't really truly, to be honest with you, I should knock on the wood because I have currently 3 or 4 patients on the trial. I have not really had too many infections or infectious complications that were initially seen in Bellini trial.
400 mg?
Yes, I know. Yes, the trials are all 400 milligrams, but I have currently a patient on 200. His creatinine is like 2. So I said, okay, let's not rock the boat. And he's on 200 and he's in solid CR at 200. So I haven't gone up on the dose and he's tolerating it well. So we don't know all that, whether 200 is a good dose, 100 is a good dose, 400 duration of therapy. We have no idea. So it's all players' choice,
A question from Dr. Christopher. Your approach for a patient who is severely edematous, either due to nephrotic syndrome or due to cardiac failure, how will you adjust the doses of DARA VCD?
So nothing for DARA VCD. I would not do D though. The little d I would not do, meaning that, the dexamethasone steroids is going to be very difficult. So whatever you need to do for pre-medication to prevent administrative-related reactions for DARA, but otherwise I would not do it, till you are able to control diuresis better. Maybe do 10 milligrams of dexamethasone, definitely no way more than 10 I would do, just because, I think it is going to worsen nephrotic syndrome. And I think I also feel that don't be afraid to go up on the diuretics. I manage my own diuretics and fluid overload. Again, we use a lot of furosemide, then, we go to torsemide. We then use, I use a lot of metolazone. I also do spironolactone to prevent, potassium loss, because taking all these pills makes it very hard for them sometimes. So potassium pills are very big. So, I do spironolactone. There is some metalloproteinase activity inhibitor, some preclinical data on that as well. So, things like that. If serum albumin is less than 2 grams per deciliter because of nephrotic syndrome, I also do IV albumin. And I do IV albumin just to give some intravascular volume, because there's so much of extravasation of fluid. So some intravascular volume, and also that it enhances diuresis of loop diuretics. It enhances efficacy of loop diuretics. Because, the way I understand it, I'm not a nephrologist, but the way I understand it is that Lasix or, furosemide or torsemide, they require albumin to be transported or to be present to the nephrons. And, if you have low serum albumin, you don't have enough albumin to really have the efficacious diuresis. So I do a lot. And, they are coming back once a week to get Cybo-D. So I just put it in IV. I do 25 grams of albumin followed by 100 milligrams of intravenous furosemide. And that is part of my treatment plan, because then at least I have some leeway to use a little bit of more steroids.
Dr. Kannan wants to know, is the eGFR sufficient or you need DTPA renogram?
So it all depends. I don't know what ATP renogram is, but we do We use serum creatinine. There is also cystatin C, which is not based on the muscle mass. But I think that, I am old, I can't learn new things. So we just do EGFR and creatinine.
A question about allogenic SCT in any patient?
Not in this day and age, because we did do in about 4 patients in our whole database in the last 30 years. And again, this was all in 1990s for young patients who had a match and whatnot. Outcomes were terrible. They all organs fail. They all develop GVH, and then some people had treatment-related mortality. And we were trying to save their kidneys, and the kidneys failed, obviously. So, allo transplant, even if it is mini, full, I would not recommend it. I think the questions are what, I think that, which is the field is moving forward, is bispecific antibodies. I don't know if you guys have it in India yet.
Janssen teclistamab we have.
Oh my God, really, Dr. Agarwal?
Yeah.
I'm telling you, I'm moving to India. So that is wonderful. This is great. So I will tell you that these agents are the BCMA CD3 bispecific antibodies. They are so powerful. They are so powerful. So, we talked about bortezomib game changer. Then I changed it to daratumumab game changer. And now I feel this bispecifics. So, I have treated few patients with the issue is there are no prospective clinical trials of teclistamab, elranatamab, or telquetamab in AL amyloidosis. So teclistamab and elranatamab is BCMA CD3 bispecific antibodies. The telquetamab is GPRC5D CD3 bispecific antibody. I don't understand why Janssen doesn't want to do a prospective clinical trial, because I think that they are so focused on data because it's the same company that is making it. So they don't want to really do teclistamab. We have treated patients off-label, off-trial with teclistamab with 1 dose. They are in solid CR, 1 dose. The problem is it is a step-up dose. So patients have to be hospitalized because they get infant dose, baby dose, toddler dose, and adult full dose. So they have to be in the hospital for 10 days at least. And that is a lot of, whatever. Have I seen CRS, cytokine release syndrome? Yeah, maybe in 1 patient. Have I seen neurotoxicity? No, not in anybody. What I do is I don't continue them on once a week. I do only first month as once a week, and that is what the standard is. And then it is supposed to be given once a week till progression. What I do is at 2nd and 3rd month, I do once every 2 weeks, and then I drop it to once a month. And by 6 months, I stop it. Now, I don't know whether they all are going to relapse at month 12 or month 18. I don't know. But the infectious prophylaxis, because these things do cause infections as well. So, but in AL amyloidosis, I have not really seen it. I do put them on a lot of prophylactic medications, antibacterial, antiviral, anti-PJP. So all those prophylactic medications are there. We do have a clinical trial of ABBV383, which is a bispecific with BCMA, but it is a molecule that is designed very differently, which is a low CD3 affinity and dual binding of BCMA domain. So the way the molecule is designed, we can do it. There's no step-up dose. It's a fixed dose, and we can do it once a month. So I have 3 patients on that clinical trial, 1 dose, and they're all in CR. It is just so gratifying. And, they don't develop CRS. We haven't lost anybody yet. So I think it is a new wave, but I think that this is really, really. How much does teclistamab cost?
Yeah, 6 months cost is 50 lakhs, but that is once a week. We also don't give once a week. So
Right.
we have used it on outdoor basis with prophylaxis, tocilizumab, steroids on outdoor basis.
Toci is expensive too.
Here we have from Cipla. So during the COVID, it became very easy to get it. So we have it. So we use it prophylactically and give it outdoor basis. And yes, because of the cost reason, we automatically go to once in 2 weeks. And now you said once in 1 month. I don't know. I've not used it for amyloid. It's all for myeloma.
Right.
But yes, wonderful drug. And
Wonderful drug. I'm telling you, I know. Amazing, right? I know.
you have to use IV gamma globulin, or because
So, again, see, the Dr. Agarwal, this is why I love to do this, So, yes, and in myeloma, we do this all the time, right? If IgG is less than 400 milligrams per deciliter, you are going to give gamma globulin. In AL amyloidosis, and I'm discussing this with all the companies because nobody really knows, there is non-selective proteinuria because of nephrotic syndrome. So even before they start, they could have IgG levels of 200, 300, because along with albumin, IgG is going to go down in the urine too. And they never ever develop infections or anything like that. So, and the companies are saying, oh my God, you have to do IVIG. And I feel that IVIG also comes in a big bag. It's a lot of volume. And do we really, because we don't know whether it is the teclistamab or bispecific that has caused hypogammaglobulinemia, because they began with hypogammaglobulinemia. So it is a challenge. I think we are learning. Hopefully in next 5 years, we will have some answers.
PubMed, there is case report of teclistamab in amyloidosis.
No, there are two reports. One is from Raj Chakravarti from Colombia. So he has done a multi-center chart review retrospective study of 10 patients. And there is also one from Greece. I think they have 15 or 20 patients with teclistamab with excellent responses. Again, nobody knows how to use it, when to stop it, because it is not really well studied. So,
Dr. Sham has two questions. One is doxycycline, any more use in AL amyloidosis? No. And
it's a goodbye to doxycycline. Chinese randomized clinical trial of doxy versus no doxy placebo, and there was no improvement in survival, no improvement in anything. So no, it's a goodbye to doxy.
Right. And second, what is the least effective dose of dexamethasone? Lowest dose of dexamethasone useful in AL.
Right. So I don't really know that, but I have used even 4 milligrams, which may be homeopathic and not really a plasma cell killing dose. But, I have used even 4 milligrams because patients can tolerate it. And, I still, I think it's treating more of me than treating the patient or the plasma cell dysplasia. But, 4, 8, 12.
Sure. Yes, Dr. Vishwadip, your question.
Regarding this body, when we have cardiac as well as renal systemic amyloidosis with cardiac involvement, sometimes they get diarrhea as a routine complication of bortezomib. But in amyloidosis per se, because they have very fragile hemodynamic system, and I had to struggle a lot with the patient, then I had to stop at 2 months. With every time she used to get bortezomib, she used to get 8 to 12 times diarrhea, and then get or some, and they live in a village, so it is very difficult for the family also to manage. So then I had to switch to melphalan because she was elderly, and she was well. But do you have any advice regarding if somebody has diarrhea, as well as few patients develop, as you suggested, the dose of 1? I think that is a good choice because few patients, otherwise no risk factor for neuropathy, they just develop frank treatment otherwise later on. Because of that, a lot of hypotension, they could not come till whenever they sit up, they get hypotension. So a lot of morbidity because of this neuropathy. So do you have any predictors like which patient we should avoid, or any polymorphism or any study you have which will help us guide?
So there are no predictors. Bortezomib is a notorious drug, I think it's a great drug, but it does, do all this. So, I think in patients who develop diarrhea, because sometimes patients get terribly constipated too. So it is unpredictable whether it's going to be diarrhea or not. But diarrhea is a common complication. What I do is obviously I tell them to take lots of Imodium. Because, it is usually short-lived for 24 to 48 hours. Lots of Imodium. There's no upper limit of Imodium till the diarrhea stops. I also suggest to take Imodium the night before and the morning of before they come in, just as a prophylactic measure. Again, whether that works or not, I don't know. But I think instead of having 8 to 10, if they have 2 or 3, it would help. Lomotil I've used as well. And then I think the other thing is this small intestinal bacterial overgrowth, because if they do have autonomic neuropathy, there's stagnation of this bacteria in the GI tract, and they can get SIBO. And if SIBO happens, then, there is a treatment for it that will help with the diarrhea. But if it is clearly related to bortezomib, I think Imodium, Lomotil, prophylactically, day off, and then just take it round the clock. Don't wait for it to happen. We also see a lot of ocular complications. I don't know why of bortezomib. That patients get a lot of styes, chalazions, blepharitis, and it is really, really, really very, it's not just cosmetic, but patients are really bothered by it. And I don't know, and we never used to get it when it was IV bortezomib. I think some of you may not have even used IV bortezomib. Dr. Agarwal and I have definitely. But, subcutaneous bortezomib, I think, I don't know. Lot of our patients. And, I speak to a lot of other physicians, even across Boston, and they don't see it. And we wonder whether it is kind of patient specific or whether it is, the generic that we use for bortezomib specific. I don't know. But we have probably, I would say, 3 out of 4 patients get ocular complications. And we use ketotifen eye drops. We use, obviously, erythromycin ointments and all that, but it is very challenging.
We don't see it at all, I would say.
Really?
First time I'm hearing.
I think, I'm talking with my pharmacy people because I think it is the drug, the generic that they use, I don't know.
Dr. Thanda, your question? Sorry, you have another question.
No, I was just thinking like whether it is the water they use and like the local epidemiologic issue, if you can check which patients have, because like I with that like this water was infected and I got it, and then I realized that every patient who has a risk of immunosuppression. There are small things which we don't discuss about with the patient, that even water source can cause a poor quality of life.
Hopefully in the United States, the water is good, I don't know. Or, that whatever I
Okay.
tell you.
Dr. Thanda, your question.
Thank you very much for your talk, Madam. I'd like to know any maintenance therapy after transplant.
Maintenance after transplant?
Yes.
Right, not generally. Not generally, unless, so if they have achieved a complete hematologic response, no role for maintenance. Because most of the time, the responses or CRs achieved after transplant, the median duration of remission is 12 years. So if CR is achieved, no role for maintenance, unlike multiple myeloma, where we are doing lenalidomide and maybe even daratumumab now, but not in AL amyloidosis. But in Andromeda, we are doing dara maintenance for 2 years. So again, these are not head-to-head comparisons.
Thank you. Thank you.
Thank you. So that's all what we have. All questions
so much.
are over. I have to be grateful to you. You don't have to say thanks to us.
No, I'm telling you, and I do this with great honor and pleasure. And it is not for anybody, it is for my own self. I truly feel that, this is so amazing.
You are a perfect teacher and you teach so much. You taught us for the last 2 hours. I think tremendous benefit. And in the bargain, the patients will benefit. And we'll keep bothering you with the request. And I'm sure
Thank you. Thank you so much.
Official vote of thanks, we have Prashant. Prashant, go ahead.
Yeah. On the behalf of Adlai, I would like to thank Dr. Vaishali for the wonderful presentation. It was really very informative and energetic too. And I would like to say thanks to MB Agarwal sir once again for giving us this opportunity. And you all have truly made this evening a wonderful evening. So thank you, everyone. And over to you, sir.
Thank you. Thanks. Good. Good night to all in India and good day to Dr. Vaishali. Thank you. Bye-bye.